All right, I think people are sort of here, and welcome, and those of you who are on your way in, because I think we're admitting everybody right now. So hi everybody, it's Barry Sarvet, and welcome to our MCPAP Clinical Conversations program, which folks know, I think, takes place on the fourth Tuesday of every month. Um, and I'm going to tell you a few things about today and also about our next session, and then we'll jump in and get started. Um, so so the first thing to say is just that we're really excited about the topic for today. It's you'll hear more about it momentarily, but the title is Early Childhood Autism Diagnosis Project, and it's about the some work that some new work that we're doing in MCPAP in the state for young children suspected with autism. And just as a heads up, our next month's program is actually an interesting topic. It's a little bit different than our usual, sort of kinds of topics. This particular one is on breastfeeding, particularly around kind of questions related to breastfeeding and medications and things like that for, obviously for infants. And the speaker is going to be Dr. Betty Wang. So you'll get information about that in the near future, and just mark your calendar for February 24th. Just a few housekeeping issues. First of all, as we have recently begun offering CME. We're continuing to have that, and so the code for the CME is Wenzol, at least today. Wenzol. It will be in the chat. And you'll sort of follow the link, and after you enter that code for the Mass General accreditation program. By the way, we continue to be very grateful to Mass General for supporting CMEs for our program. This session will be recorded, and it's going to be on the website under the toolkits and resources tab, and the website address is easy. It's mcpap.com. We will take questions, and because it's clinical conversations, that we want as many questions as possible, and we want to talk about the material, with you. So feel free to enter your questions in the chat, and we can either read them and answer them, or we can unmute you, and you can ask yourself if you prefer. So just let us know what you prefer. And at the end, we would like you to look out for a brief survey, just so that we can continually improve the program. All right, so I want to introduce our distinguished speakers. We have two speakers for today, and both of them are our co-conspirators here. They're part of our MCPAP, team. And the first is Dr. Yael DeVere, who actually is the team medical director for the Western Central team. Is actually co-medical director with Dr. Bruce Waslick. And she is a child and adolescent psychiatrist at UMass. And she also happens to be the director of the Child Psychiatry Division at UMass and the vice chair for the Department of Psychiatry. She has lots of different clinical interests, but the one that's most relevant for today is that she's been quite interested in early childhood mental health, and has been leading our arm of the program that we have, a new arm, which is referred to as MCPAP for early childhood, and it's a branch of our program, and she leads that service, and is also very actively involved in training child psychiatrists in her fellowship program, and to doing all kinds of collaborative work to improve access to care for kids with mental health problems. She also has research interests, which include health services research to improve access to care for kids with mental health problems, as well as early childhood mental health and mood disorders and trauma and psychosis. And she's a very, very diverse interest. She received her MD from the Hadassah Medical School at Hebrew University of Jerusalem and completed a residency and fellowship in psychiatry and child psychiatry, respectively, at UMass, where she is a full professor of psychiatry and behavioral health, behavioral sciences, and peds. Our next speaker, in addition to Dr. Tavir and collaborating with her on the presentation, is Elizabeth Turan, LICSW, who is one of our clinicians for MCPAP. She is an early childhood expert and is involved in the helping us to deliver the MCPAP for early childhood program. And she also works at the CanDo Center for Autism and Neurodevelopmental Disorders Clinic at UMass. She has worked with children of all ages and families and adults, particularly in the area for interest in autism spectrum disorders and chronic and persistent mental health problems. And she is currently the person who is providing the CARS-2 evaluations, which you'll hear about momentarily, for young children to provide formal diagnoses of autism. And also she wants us to know, and we should know that she has lived experience as a parent supporting children with neurodevelopmental differences and mental health issues, and is an adoptive parent. So I will, without any further ado, hand off to Dr. Tavir and Elizabeth Turan, and look forward to an interesting presentation.
Thank you, Barry. Just give me a second here while I am putting up my slides. Okay. I somehow lost the videos of everybody speaking, so let's see if I can get you guys back. Gonna start again and see if it works this time.
Gail, you can't see the participants or the slides?
Yeah, no, I couldn't see the participants. So I could only see the slides.
Oh.
Right now I'm seeing. Okay.
There's a view tab or up on the banner, sort of above the main window. There's different tabs, and there's one that's called View on my screen. Do you see that one?
Yep. Let's do that.
If you click on that, you might have an option to see like the participants too.
So now, are you now seeing the slides but not the presentation?
We're seeing your window of the slides, and now we see the presenter view.
Okay.
So we see the main slide and the next one.
Okay.
And now it's perfect.
Well, it's perfect, only that I still can't see.
It's perfect for me, but not for you.
It's not perfect for me, so I don't know. Let's see. I'm trying.
So if you click view, do you have an option that says gallery? Because that's sort of, I think that's what you want.
Well, it was all good before I started sharing, so let's try gallery. And let's try presenting. Okay, you know what? This should be good enough. I'm just going to pretend that I see everybody's smiling faces until the slides are over. So we should probably stop trying at this point and just get on with the presentation. So thank you, Barry, for the introduction. So Liz and I are going to be talking about our early childhood autism diagnosis project, which started in the central western part of the state and is now going statewide, and we're pretty happy about that. And this is really about bridging early identification and timely diagnosis for autism, which we believe is an important thing. This is our team. So first of all, we have HRSA funding. The grant is operated by the Department of Public Health and flows to MCPAP to conduct this. And I direct the project, and our team includes, on top of Liz Thesselteren, also Carolina Clark and Erelsa Oliveras, who are our social workers and family partner for the program. Just a little bit of background. Why is this even important? Why is early diagnosis important, and why does it matter? So we all know that early interventions improve the outcome in young children with autism spectrum disorders, but that delays of 6 to 18 months from positive screen or suspicion are quite common because of difficulties accessing diagnostic evaluations in a timely manner. And those disparities in access to care especially impact under-resourced families, and MCPAP is very much a program that tries to address such things. The gap here is that there is a long wait between screen and diagnosis, probably related to many factors, but some of them are shortage of specialists, so either psychologists trained in conducting evaluations or developmental behavioral pediatricians who are able to conduct evaluations. And all of the referral pathways for autism diagnosis are quite complex and not necessarily easy to access. There are existing early autism diagnosis models. So there is a tiered hub and spoke diagnostic system, primary care embedded evaluations, and one example is the Delaware model. There's just in general a growing number of states and healthcare systems that are developing primary care embedded diagnostic models to sort of close this gap between screening and diagnosis. And it allows primary care clinicians to initiate a structured ASD assessment and also maintain a pathway for more complex referrals. So in Delaware, their model, for example, it really sort of empowers the pediatric spokes to perform preliminary diagnostic assessments with primary care and only refer those cases that are uncertain to those sort of regional hubs for full evaluation. And, you know, there are generally multidisciplinary evaluations, and those models have reduced wait times from several months to a matter of weeks and increased the diversity of kids who are able to access some of those assessments. So those expedited protocols showed that community clinicians can, in fact, reliably conduct structured autism interviews using validated tools like the CARS, so the Childhood Autism Rating Scale, second edition, which we will talk about later. And they can use those when they're trying to support consultation and sort of multidisciplinary assessment with oversight. And so this suggests that it doesn't necessarily we don't necessarily need to limit the accurate diagnosis to ASD to specialized tertiary centers. We can really extend this into medical homes where children receive their most earlier care. So that's kind of a background of how we came about engaging with the model that we have. As I said before, we have enough evidence to suggest that the diagnosis of ASD is reliable when done by community clinicians. If there is support and oversight, which is what MCPAP is really built to offer in many areas, and it validates that those sort of observational protocols like the CARS one is really helpful in being able to conduct this. So just reviewing what are the standard diagnostic tools. So we know that ADOS is the sort of gold standard. We also know that it is an assessment that requires the assessor to be quite well trained, and it is a timely assessment. Um, it is highly sensitive, very resource intensive, and it's not exactly feasible to be able to use ADOS in a community setting because of all of that uh, background limitation that it has. So that and the data suggesting that is helpful is why we have chose to use the CARS 2 for our assessments. It's relatively brief and it's behaviorally anchored. It's low cost and it's scalable, and it is appropriate for the preschool population, which is the population we are targeting. There is significantly positive psychometrics for the CARS 2. The consistency, the internal consistency is over 0.9, and the sensitivity and specificity are quite high as well. A little word about how the CARS work. There are 15 domains of social and behavioral function, and a score of over 30 indicates ASD. And it is an effective tool when there is sort of a consensus diagnostic model. So our program overview, and I'll be very brief because Liz will tell you more about how this operates, is through our HRSA-funded project that piloted in Central Mass first and is embedded within the larger MCPAP for early childhood. And it focuses really on both equity of access and timeliness and evaluations. We assess children 18 to 6 18 months to 6 years, and we ask for a positive MCHAT or other developmental screen. And for older children, um, we usually use a screening that uh, is based on the DSM-5 diagnostic criteria. And of course, we take all comers regardless of their insurance. The diagnostic model is a 2-visit assessment with the administration of the CARS 2 and integration of the DSM-5 criteria into that. And then passing this on to the primary care who initiated the referral, reviewing the findings together. And the primary care is really the one signing off on the diagnosis when they receive all of the assessment materials. We have a family partner that's working with us, who's bilingual and helps navigating the diagnostic process and offers support and culturally responsive care to families. Just sort of quick preliminary results since we've started this. Liz has assessed 61 children. 73% of them received a diagnosis of ASD, and the mean age was 45 months. And what we are seeing in terms of impact is that we're able to offer a diagnosis within 8 weeks. There is very high family satisfaction with the process. And clinicians working with us are feeling increasingly confident working on this collaborative model. Why it works. So it works for a number of reasons. We have a standardized tool. The CARS is a standardized tool that helps structure the assessment in a helpful way alongside the DSM-5 criteria. It is also what is needed for letter for medical necessity to receive ABA or equivalent services in the state of Massachusetts. So that is important. We're using the consultation model and building upon the existing MCPAP structure to allow primary care the same access with the same phone number to services that they use for all of their patients' behavioral health needs. And for the families, this is embedded in the medical home. By the end of the process, the pediatrician, the primary care clinician is the one holding the family with this, with our support, which we know, and there's plenty of research to suggest, is a very helpful way to approach medical needs, developmental needs, behavioral health needs, and specifically in this world and age where autism is no longer a rare diagnosis, it does make sense that this lives within the medical home of the child and family. Next steps, as I mentioned, is the expansion statewide. We're really hoping to strengthen our coordination with early intervention and to track some long-term outcomes to see how this is going um, throughout the state and sort of see how this program is something that might be a model for other states using early childhood assessments in their child psychiatry access programs. And with that introduction, I am going to pass this on to Liz.
Okay. Okay. Thank you very much, Dr. DeVere. Um, I'll continue talking about the CARS 2 evaluation. So this presentation does an overview and then more of a deep dive into the process. So as you probably know, calls come into the MCPAP line and are triaged. If it's a child between ages 1 and up to age 6, then the call is sent over to an early childhood behavioral health clinician. Then there's a clinical review and such on the phone, and if the question is autism, Carolina tells the primary care physician about this program and the nature of it being a collaborative process between myself, a clinician, and the PCP. And to be screened in, children under 3 require a positive autism screen. For example, an MCHAT, encourage early intervention referrals, or sharing of EI information if it's completed. For children over age of 3, there must be concerns in 2 areas, which are used in the DSM-5 for diagnosis: first area, deficits in social communication, social interaction. Second main areas, restrictive, repetitive patterns of behavior, activities, interests, play, and such. Next slide, please. Okay, so the children who meet those criteria are then referred to have an autism evaluation with myself in LICSW using the CARS 2, which is the Child Autism Rating Scale, the second edition, and it's the ST form standard used for children under age 6, children age 6 and older who are verbal. There's a different form of the CARS to use to administer the eval to them. So what the format we've set up is a 2-session evaluation using the CARS 2. First sessions, about 90 minutes is allowed. Sometimes it's all needed, sometimes not quite all of it. And it helps to observe a child directly and get information and feedback from the parents about the child's behavior and such at home. Helps to determine if there are certain behaviors we're looking for that are, red flags for an autism diagnosis, and also enables a clinician to quantify how significant that concern is. The CARS, as Dr. DeVere mentioned, has 15 different rating categories. Ratings are between 1 and 4, including half numbers: 1, 1.5, 2, 2.5, and such, with 1 being completely typical in that particular area, all the way up till 4. The higher ratings on a particular in a particular category need to show significant like frequency of the behavior happening, frequent intensity as well of how engaged the child is in this behavior, how hard it is for them to stop and such. So through the clinical interview and parent feedback, playing with the child, observing the child, that's how the information that's used to score the child autism rating scale. Next slide, please. So in the, well, I should probably mention, so a score is achieved at the end of the evaluation. As Dr. DeVere mentioned, score 30 and above is consistent with an autism diagnosis. The range from 30 to 36.5 is consistent with mild to moderate symptoms, and severe symptoms of autism, significant, very significant, are for children who have scores of 37 and higher. So complete the child autism rating scale and such after the first appointment. The second appointment is scheduled typically at telehealth, just to avoid the need for parents traveling, but it's only with one parent or parents, or if there's another family member they want involved. Sometimes early intervention workers attend, which is fantastic. So at this appointment, the diagnostic impressions are shared with the family. I generally go through the two main categories, the social communication, repetitive behaviors, and play, bit by bit, and share some of the ways that there are concerns in that particular area or no concerns. An eval is written up and sent to the families. The first session, including the CARS rating scale, as well as the clinical interview and such. Second session is also written up. Generally, it contains a number of recommendations, which we ask families to try not to be overwhelmed by. It's kind of think of the 6 to 12 month frame work, but it's important to get the information out there that there are different things that can be helpful. So these two evaluations that are written up are shared with the family and also shared with the primary care physician. I always have a phone conversation with the PCP just to touch base, let them know the CARS score, see if we're both thinking along the same lines as far as diagnosis. The responsibilities on the PCP to use the information from the CARS eval and their diagnostic letter report. And then the way we modeled it is the family partner initially joined part of just at the end of the session, so that it would be a warm handoff to the family partner to work with the family. But we found it to be more successful to have the family partner, Relsa, attend for the entire appointment. She adds things, reassures parents too. She just contributes some significantly. So it's helpful. I always let them know. I mean, she's a fierce advocate, but she's very respectful of parents. And this is the perfect balance, I think. If a parent is interested and wants help, she's available to help as much or as little as they want. It is always up to the families. Let's see. Next slide, please. So the children that are referred need to meet certain screening requirements, and the expectation is that the majority of them will probably receive an autism diagnosis because, of course, the PCP knows them very well and has noticed a number of red flags. However, sometimes the evaluation for different reasons is more complicated. If the score is in a borderline range or just barely meeting the scoring range for diagnosis of mild to moderate autism, um, I'll give that a lot of pause and really review things. We work with a specialist consultant who's a developmental behavioral pediatrician to whom we can refer these children for an evaluation. They go to the front of the line, so the children don't have to have an 18-month to 2-year wait, but it's decided clinically as a team if this is appropriate. If the second, more intensive look using the ADOS, of course, would be most helpful. Um,
Hey, Liz.
oh, yes.
Yeah. So there's a couple of questions that came up,
Okay.
but either for you or for Dr. DeVere to address, and I wonder if you could speak to sort
Sure.
of the difference between, this CARS 2 evaluation and, the kind of classic sort of neuropsych evaluation referral, which is
Hmm.
sort of a pathway that people have, historically, often thought of,
Hmm.
for kids suspected of autism. Yeah,
Hmm.
to start with.
Yeah, sure. Um, as was said earlier, the ADOS evaluation is really the gold standard. Um, a lot of training is involved in um, a person becoming competent at administering that um,
Yeah.
evaluation. So as I'll get right to the point. I'm just mentioning that
Oh, yeah, yeah.
as time has gone on, it's generally been developmental behavioral pediatricians who have provided the ADOS, and the clinics have been just overwhelmed with referrals. So at this point, they're generally only accepting referrals of the youngest, very youngest children. There's long wait times and such. Um, there are other pathways to a diagnosis. Like I had said, the ADOS with a developmental behavioral pediatrician, um, or a neuropsych evaluation. Um, Waits for neuropsych evaluations can be long. Um, Different agencies accept some insurances, not others. So, and it can be a complicated process for a family to advocate um, to be able to obtain a neuropsych evaluation, especially if English is their second language. So it can be done if, as long as in the referral for a neuropsych, it's specified that this is a referral to specifically look at if there's an autism diagnosis or not, because then they can include certain questionnaires, rating scales, and such that would help them to make a diagnosis.
Mm.
Does that answer the question?
Yeah, well, yes, definitely. And maybe we could also sort of speak to, I think there's kind of an implication in the question that, that the neuropsych, is, preferable. If we only had enough, sort of the resource. And, it is it's like not an apples. I guess what I would say is it's definitely not an apples to apples comparison, that there are sort of different indications for a neuropsych evaluation than for an autism evaluation. There's also an overlap, in terms of, sort of things that really kind of correspond to both, and so you sort of could use, your cars too, as a substitute for part of why you would refer a patient for a neuropsych evaluation, but not, necessarily, kind of just as kind of like a substitute. The cars wouldn't be a substitute. What you have thoughts about that, Dr. Javier, as well? Yeah.
Yeah, so I was going to say, just taking a step back, MCPAP as a whole is designed to help mild to moderate cases. And over the years that MCPAP has existed, it has also followed other trends that were happening around us, including where autism is now a fairly common occurrence. And so the way we think about this is that this model is really designed to help those kids and families where the primary care clinician walks into the waiting room, and brings the kid in and really knows that they have ASD, there really isn't a need for a full neuropsychological assessment or the full administration for the ADOS. In terms of how we look at it as providers, it's a clinical diagnosis, and what we need are for DSM-5 criteria to be met, right? But to get services in place, we need to have a standardized tool. And so CARS is a great tool to help us, access services for families where the diagnosis is not quite as complicated. So I think there is a place and a time for a neuropsychological assessment, for a full developmental behavioral pediatrics assessment using an ADOS, but there is also a time and place where a child who has a very clear presentation can get access to services faster. And I think that it will help if we keep going, because I think Liz has a case that illustrates why
Great.
this is
Great.
actually offering, great service with this specific screening tool, and, which has a good amount of evidence to suggest that it's pretty sensitive and specific. So,
Yeah. I want to add one point, if you don't mind, is, and then we get to the case. But the way I think about it is that, as you said, that this is a good pathway to kind of get the diagnosis. Like, we can make the diagnosis, you can make the diagnosis, any primary care provider can make a diagnosis of autism, by applying DSM-5 criteria, and that will be a valid diagnosis. That's just as, appropriate as any other kind of pathway to the diagnosis. And so you need that diagnosis to start in, to get services, to get the school to start, providing services, and to sort of get to work, with APA. But later on, once you sort of get those services in place, there are questions that arise about whether there's any complexities to different kind of developmental profiles that might be encountered. And so it could be argued that every child with autism should, at some point, in their development, get a neuropsych evaluation, but that shouldn't be your rate limiting step, to get services, and so this is kind of like a more abbreviated clinical sort of assessment that allows you to get started with services. But it shouldn't be used. I don't think neuropsych evaluation should be used as kind of like a gateway, because they're so hard to find and they lead to major delays in care.
Right.
So, okay. Sorry.
Okay, and I'll just mention briefly, I happened to see a question going into the chat about the application and relationship to DDS, the Department of Developmental Services, and I'll mention that's among the top recommendations that's included in the write-up for the second evaluation, because it offers many opportunities for additional services and support.
Yeah. There are two questions in the chat about signing off. So could you speak to that, question about just the sign off? Because it sounds like there's some concern about that. Yeah.
Um,
Or do you want me to read it?
Well, sure, just to make sure I'm answering.
Yeah, I just didn't know if you
correctly.
see the chat, since you were seeing the
I've been talking and I have
participants.
I've been
Yeah, so
watching
it
it
says,
except for that last one.
so why does it need a PCP to sign off the diagnosis? Isn't that an extra step that doesn't add much to the diagnosis? And then there's another question that says, how does the PCP sign off? Okay, go ahead. Yeah.
I'm going to take that one. So, okay, so the way that this works in terms of acceptability of a diagnosis using a standardized scale is that a diagnosis can be made by a doctoral level clinician, so an MD or PhD, PsyD, DO, and so Liz, who's got a ton of experience and is an LICSW, so that's not enough for that sort of letter of medical necessity. However, I do want to say that I don't think that this is um, adding an extra layer that isn't needed. I think that the way we look at it is very similar to the rest of the way we look at our consultation model in MCPAP. This is a collaborative process. While the team, Liz and team, put an effort into conducting a thorough assessment in those 2 sessions, as Liz is going to describe, the primary care provider clinician knows the child the best, has made the observations of behavior and development long before this child and family were seen by us. And being able to work collaboratively on having the family accept the diagnosis, get into services, receive care is really an important value and is important to having a medical home model to kind of, help carry this on for the family and walk with them. So I actually think that even though this was originally designed this way because of the sort of limitations of what insurance companies want, there is real value in this process. And we do a lot of hand holding in making it easy for our primary care partners to feel comfortable with this. So I hope this sort of answered the question. Liz, if there's anything you want to add on that, I think that would probably be helpful, but I really think it would be great to kind of clarify things with going over the case and getting a little bit more into the criteria.
Okay, great. Let's do that. We're starting to run, getting close on time here. So I'll just mention this slide shows in step-by-step form what we've been talking about in terms of the process of obtaining an evaluation, receiving the evaluation, and post-evaluation, what happens. First thing we always ask families to do is to schedule an appointment with their child's PCP to review, discuss the evaluation, and discuss together any referrals for services. Next slide, please. So circling back, well, I guess it's kind of a spiral, I guess. Circling back, again, this is a closer look at the steps in the process of receiving referrals. Oh, and I should mention, referrals need to come from the primary care physician or primary care APRN or nurse practitioner or whichever. If a community provider has concerns about possible autism diagnosis, we encourage folks to talk to the family about it, and the family needs to contact the PCP to discuss this. Let's just go to the next slide, please. So when Carolina, the licensed social worker, has the call with the PCP, this is an example of the run through of what happened, overview of what happened in a particular referral and evaluation with identifying information withheld. I'll mention, I happened to see a piece of a chat question, and the program as it is now has LICSWs doing the CARS evaluations. I don't see why an LMHC couldn't after they had, the particular training. I went through training for the to be able to administer and score the CARS too. So I don't see anything. So a particular child was referred. They had a positive MCHAT 2 years prior, and they have this child has 2 siblings at home with disabilities. One, a sibling who has autism and is nonverbal. The other sibling, and they're both older, and the other sibling has some hearing impairment, Down syndrome diagnosis, autism diagnosis, and as well as nonverbal. The child that we evaluated the PCP was wondering if some of the behaviors that were being seen at home could be imitations of behaviors of the siblings. This particular child, speech wasn't developed at all, very limited, not used in a functional way to communicate, very poor eye contact. During the eval I had with her, only one brief, fleeting moment of eye contact. Now, this particular family continues to face, but faces many barriers. They're a refugee family, pretty fluent in English, but English is a second language. But being a refugee family, not familiar with the systems in this country, how it all works, and what's available, can compromise early diagnosis or moving on to treatment. For this particular child, genetic testing they had it, and it was not remarkable. Oh, and because this family had these additional barriers, they never connected with early intervention. They didn't know about it, or they couldn't figure out the system. The time that I met with them, the child was in public school, pre-K. And she was 5 years and old and plus 2 months at the time of the eval. Next, next slide, please. So we had the first appointment on the CARS ST. She received a score of 36.5, and that falls in the range of mild to moderate symptoms consistent with autism disorder. The purpose of the eval it's given as a preliminary diagnosis, which then can be verified and formally made by the PCP. So look at the next slide in a moment. But again, DSM-5 criteria need to be met in two main areas: social communication and then repetitive behaviors, speech, play, etc., in order for a diagnosis to be made. She had many behaviors, which I'll talk about in the next slide, which led up to this symptom. And I'll mention too, the 36.5 is the very top of the mild to moderate range. Next slide, please. Two. Okay, so the next to this slide and the next one, I'm going to speed things up. Review the DSM-5 criteria for a diagnosis. In the first area, social communication, there needs to be, for a diagnosis, there needs to be at least one characteristic in each of these three areas. Well, we'll talk about the next one after. We're very fortunate. We use the psychiatrist who led us in the training, himself had a training which he received a tool from CHOP, Children's Hospital of Philadelphia, which maps basically the CARS rating scale, observations, results, ratings, and such onto DSM requirements. So it is a really comprehensive way to show the CARS, show the scoring, but also show how a child, meets criteria according to DSM-5. Okay, so one big area, deficits in social reciprocity, atypical nonverbal behavior. As I mentioned before, this child had very poor eye contact, responded to her name inconsistently, very limited use of gestures. Actually, she wasn't using gestures to communicate. In my training, one of the things I've learned is not having the ability to use a pointer finger to indicate something that's wanted, is a very big, pretty big flag. Let's see. And imitation as well, the ability to imitate sounds, words, behaviors, and such. Next slide, please. So the second area that child needs to meet criteria for is the restrictive repetitive patterns of behavior. Meeting the criteria is different in this segment. The child needs to meet criteria in at least two or more of these four broken down um, symptom lists. And then if they meet the criteria for section one as well as two, then a diagnosis is made. This one, as you can see, this girl showed significant echolalia, had flapping, hand flapping behaviors, some of the ways she met criteria in that first section. Very difficult time with transitions. That one, yeah, that one's in the second section. Transitions from one activity to another or from one setting to another. Very frequently really difficult for children. Sensory issues is another one of the ratings where that are looked at, as well as if there are already by that age restricted or fixated interests or repetitive play, which this girl had. She had never seen a Jack in the Box toy, and she was delighted with it when I brought it out, but she engaged in this play over and over and over, and then would go to something else and would come back, but always having the same scripted response after the um, little Jack in the Box toy popped out. Next slide, please. So the feedback session, Rosella Veras, the family partner, joined. And this was one of the more difficult feedback sessions. The father cried and cried and cried. Just didn't stop crying for the whole appointment. The mother appeared to have gone just shut down, completely shocked. And part of it was like this child, their youngest, this from their perspective was the golden child. I mean, she was using speech. They had high hopes for her. The other two children had have significant disabilities, and they had a lot of high hopes and such for her. Plus, their cultural experience that they bring to the table is also very significant. Their particular culture, diagnosis with a disability is frequently seen as a punishment by God, referred to in very derogatory terms, very stigmatized, and children with disabilities receive very little education, and there are very few resources or opportunities for treatment. So the family the parents bring this to receiving the diagnosis as well, not only to the needs of their other two children, but this cultural perspective, which we tried to be very sensitive to, and Harelsa as well, moving on. Next slide, please. I'm going to go through this. Just some statistics, 61 evaluations, completed evaluations at this point. 44 children received autism diagnosis, 23 in the mild to moderate symptoms range of scoring, 21 in the more severe range. And some of the children that weren't diagnosed, 4 evaluated, they weren't given a diagnosis. Some, the evaluation was incomplete. Parents, dropped out or didn't continue following through. Or they were referred to the developmental behavioral pediatrician for more in-depth evaluation. It's been a lot of positive feedback. Here's one of them that received from one of our Spanish-speaking parents, new in my heart, he had autism. Thank you for the information and the support. Next slide, please. A couple of more feedback quotes from primary care physicians and the families. One primary care physician talking about it with them and thanking them for their participation. They said well, you will be hearing from me a lot. Or also, I've been trying to get help for this kid. No one will take them. So thank you so much for trying to help. Another physician. I just need someone to back me up on this, so thank you. As you see, another child, the parents gave feedback to the family partner. You were an angel. I don't know what we would have done without you. Another mom, thank you so much. That makes perfect sense. I can now understand him when learning about sensory differences and how that can trigger social issues as well as behavioral issues. This started out in Central and Western Mass, and just addressing the question, and um, um, was begun in Eastern Massachusetts, 2 sites, in October, October of this fall. So they're off the ground and running, and that's about that. There's a website where you can learn more about the collaborative early childhood autism diagnosis project. And next slide, please. There's this is kind of a summary form of a poster we have, and flyer, used as a flyer, providing information about the MCPAP program. As you can see, the MCPAP autism program is now available statewide. Next slide, please. Okay, and thank you. Have any other questions come up in the chat, which I'm not generally been monitoring? Or does anyone else have any
there's a
questions right
few.
now? Okay.
Thank you, Liz, and and this has been really great, and for Dr. DeVere as well. Yeah, there's a few. There's one saying asking about is the program only for Central and Western Mass? What about Eastern Mass?
And that's I just
You
mentioned
said
it
that, yeah,
spread, and
yeah,
yep, this
yeah.
past fall.
Yeah.
And
And
then
in Eastern Mass, the hub where the assessments are happening is at Boston Children's Hospital. And they're ready to take evaluations from referring providers.
Yeah. There were a few questions in the beginning of the session about, sort of the cars too, and whether it costs money and who can do it and that kind of thing. And I think that they may have been sort of coming from not knowing that MCPAP is going to be actually doing this for you, remotely. And but if you have a lot of autism in your practice and you wanted to build resources, that's always an option. And my understanding is, and you correct me if I'm wrong, but I think that cars too can be done by when one person asked if an LMHC could get trained, and I think the answer is yes. Although I'm not sure that the state would accept that because of the licensure requirement that we were talking about before. But can you speak to that?
So any clinician can get trained on cars. It's actually a quite affordable scale. I mean, we do purchase it, but it isn't a very expensive
Yeah.
scale to use. Before Liz started doing the assessments, she was trained by folks who are familiar with us. And then it is actually not quite as simple as just getting the training on the scale. Like, there was a good amount of supervision for Liz, who's a very experienced clinician, on how to actually make the calls in specific cases. I would say the first 6 months were really with supervision of an experienced assessor of autism. So there is that caveat. And then you do need to be able to sort of sign off on the diagnosis as a physician or psychologist. So yeah, an LMHC could learn, but they would need a significant amount of support. I do want to say on that website and with contact with a program, we sort of the way that Liz's notes are, there is all of the scoring of the cars information in them. And there is also a template for primary care diagnostic letter, which includes prompts to using those cars to scores. and all of the DSM-5 criteria seen in the specificate. So you can really like copy paste into that letter and use that as the diagnostic letter. You kind of add some of your own observations as a clinician, but it is done in, as we said before, it's really done as a collaborative process.
Mm. And then I think, this is already, I think you spoke to this already, but there is a question about, suspecting, or if a PCP has a child in early intervention, the early intervention specialist suspects ACD, can they be referred even if they didn't have a positive autism screen? And I think the answer is yes. I don't think we have any formal, sort of requirement that someone had sort of screened positive for autism before we do it. But you guys let us know. Yeah.
So we encourage a screen to be done, but if it hasn't been done, the triaging of the early childhood clinician with a primary care provider on the phone includes going through sort of
Yeah.
what an autism presentation is. So yes, we are very much into not adding barriers,
Yeah. Thank you. That's great. Yeah. So I think, the spirit of it is that, we don't want to be administering this assessment, sort of on people other than those who are, really detected and, suspected as, that they might have autism, but we're not like really that, kind of, sort of rigorous about, kind of requiring the piece of paper. Um, I don't see any other questions. Let's see. Do you see any others?
Yes, there was a new one just posted. That's the question is, in
Oh,
order for a child to receive autism services, person had heard that was taught that the diagnosis needs to come from a psychiatrist or a developmental behavioral pediatrician, and that is accurate. That's why this is a collaborative
yeah.
diagnosis program. PCPs don't have time to be administering the
Mhm.
cars and scoring it, and in the very short appointments which are allowed. So that's how we collaborate. I score the cars, do the developmental evaluation, give the information to the PCP, and then in turn, and make it preliminary diagnosis. But then the PCP is the one who writes their diagnostic letter and formally makes the diagnosis. ABA services is pretty much the one you might be referring to. In order for a child to receive ABA services, that diagnosis has to have been made and made by someone with a PhD or medical degree.
Yeah, but not developmental peds or psychiatry. And thank goodness, developmental pediatricians are even more rare than a lot more rare than child psychiatrists. So this has been a major. I think that belief, has been prevalent because of some school districts that have historically, sort of said things like that, and it's just not, practicable. It's really not workable. Well, we have gone over time. I'm very sorry for folks, to be running late, but we had some good questions and we had a fantastic presentation. And I just want to thank our speakers for doing such a nice job, and for, Beth and Pravina for helping to organize everything, and for all of you for attending. And we'll look forward to being together in February 24th for breastfeeding. But thanks everybody for coming.
Thank you very much for having us.
Thank you.